Pre-health shadowing is a virtual platform that allows students from all over, not only the United States, but the world, to connect together. Welcome, everyone. Great. All right, just some housekeeping things before we begin. If you are currently not receiving emails and you would like to receive emails, there's a few things that you can do. You can go, first of all, make sure that you are signed up on our email list. You can do this by going to the website at the bottom left, www.prehealthshadowing.com/join-us. Once you do that, you are signed up for our email list. What you can do is go to your emails and spotlight search pre-health shadowing. If you mark our emails as important, this will tell the email provider to take pre-health shadowing emails directly to your inbox rather than going to spam or junk or to promotions. This gets sent to these various boxes because of the number of links and pictures that we send in our weekly emails. And so by doing this, you're just letting them know, I actually do want to know what's going on with pre-health shadowing. Another thing you could do is save pre-health shadowing as a contact. And this is another thing to ensure that all of our emails will go to the inbox. If you guys have any questions about any of this, feel free to email us at info@prehealthshadowing.com. I have another update for you all. We now have closed captioning for all of our live sessions to accommodate students with hearing disabilities. This will be activated at the start of the presentation. Our website has been going in and out of failures, and this is due to the high influx of students that we've been receiving recently. I'm asking you guys to please pull out your phones and contribute what you can to our program. We are a student-led nonprofit program and run solely off of the kindness of our students. And so while we don't expect everybody to financially contribute if you are not able, we do ask that you post this on your social media and that you send it to family members who are looking to support your education. I'll leave this up for a few more seconds so you have the opportunity to scan this QR code. You guys can also find this on our website. On the menu tab, there is a donate button. Alrighty, if you post pre-health shadowing on your social media, be sure to tag @prehealth shadowing to get reposted on the official page. If you guys are joining us for our live session today, go ahead and post on Instagram, TikTok, Facebook, and Twitter that you are joining us for virtual pre-health shadowing tonight. This is not a secret organization or anything. We actually want as many people to know about this because this is a free program that is accessible to anybody in the world who has access to our website. We are working to fight inequalities in health education and promote diversity in various health fields. So please help us out by spreading the word and tagging us. With pre-health shadowing, students are able to take a post-shadowing assessment to verify their virtual shadowing hours. This will be opened at the end of our session today. So I encourage you to take good notes and ask questions. You guys can ask questions, you can drop them in the chat throughout the entire session, and members of our student team will be recording your questions so that we can ask them during the Q&A portion of today's session. Without further ado, I would like to welcome to you our guest speaker for today, Dr. Hardeep Kataria. Welcome.
Thank you so much to Nina and your entire team. You've all been so wonderful in helping organize such a great event, and obviously to make this shadowing opportunity available during these really difficult times. So thank you very much for having me. So I'm just going to share my screen here and then we'll get going. Okay. Okay. Am I up? Good? Okay.
Yes.
Okay, very good. Thank you for that clarification. All right, so my name is Dr. Hardeep Kataria. I am an optometrist and I currently am practicing in LA, California. I saw everybody's from all around the world, so I'm really excited to speak to everybody today. So today we'll be going over what is optometry, how your day looks like as a typical optometrist, what the education path is like, some cases that I've seen during my career, and just some interesting notes and tips and tricks on how to get into school. So some disclosures: no financial compensation for this presentation. All cases presented and associated information is my original work, including photos. No patient information was compromised and no HPI is associated with any of the cases that are disclosed. So what did my education track look like for an optometrist? Well, I graduated from the University of Florida in Gainesville. And then that was my Bachelor of Science 4-year degree. And then right afterwards, I matriculated into the New England College of Optometry in Boston, Massachusetts. It's a 4-year degree. So just like you would matriculate into medical school for an MD degree or for dental school, there is a separate optometry school. And it seems to be a lot of confusion about that in the pre-health community. So it is a separate optometry program. And your first 2 years are essentially based on basic sciences, anatomy, pharmacology, and some very intro classes and labs for procedures that you would perform during an eye exam. And then the last 2 years will focus on your clinical experiences, ocular disease, and the types of specialties that we'll go into. So then after that, I chose to pursue a primary care and ocular disease residency at the Baltimore VA in association with the University of Maryland. And then after that, so that was a 1-year residency program. And then after that, I gained my fellowship, which is also optional, with the American Academy of Optometry. And so we'll review a little bit about that as well. So we're just going to minimize this here. So what is a doctor of optometry? So a doctor of optometry is actually the front line of primary eye care. So they examine, diagnose, treat, and manage diseases and disorders of the eye. They play a major role in an individual's overall health and well-being by detecting systemic diseases such as diabetes and hypertension. So you've all heard the expression, the eyes are the window to the soul, the eyes are the window to your overall health. And that's, I don't know about the first one, but the second one is definitely true. Your eyes are the retina, which is the tissue at the back of the eye, is the only place in the human body where you can actually see live blood vessels, okay? And actually in clinic just a couple months ago, I was able to see a cholesterol plaque that had been thrown up from the common carotid into the internal carotid through the ophthalmic artery and right into the central retinal artery. And I physically saw that move. I wasn't obviously able to capture it on camera because it was moving. So that's actually a very interesting to note that you can tell the patient's overall health by looking at the retina and doing that exam. So you can see bleeding at the back of the eye, you can see arteriosclerosis of the vasculature at the back of the eye. So optometry, this is all within the wheelhouse of optometry, okay? There's a common misconception that optometrists will focus on contact lens prescriptions and fittings and glasses, and that's definitely a part of it. But the other part of optometry that is not as well known is that, yes, optometrists are able to not only diagnose diabetic retinopathy, for example, but are also able to manage that and then work with other healthcare providers, such as the primary care doctor, the endocrinologist, the nephrologist, cardiologist, neurologist. Anybody who needs to be within that team managing that patient will manage with an optometrist. So how do you become, again, a doctor of optometry? Well, you've got your 4 years of your undergraduate degree, then your 4 years of an accredited optometry school, 1-year residency, which is optional, and then you can specialize further by gaining either your fellowship or you can become a diplomat of the AAO, or you can become both. So once you're out and practicing as an OD, what types of settings can you practice in? Well, there's definitely a variety, a huge plethora of options. And this talk is really, I won't say limited, but it applies mostly to the United States. And so you can practice in a corporate and retail setting, in a private practice setting with another optometrist. You can practice in a multidisciplinary setting, which is like an OD-MD setting, and that MD tends to be an ophthalmologist. So personally, that's my practice setting at the moment. You can practice in a hospital setting. So what does that mean? Well, that's usually the VA. If you are on call for a hospital for inpatient care and emergencies, then that's usually because you're associated with a private practice in the public sector. Typically, optometrists are not hospitalists. Okay, so I don't want you to get that confused. It's typically in the VA setting where you will be taking care of inpatients and outpatients. In an academic institution, obviously, so you can be faculty at an optometry school and you can do the teaching aspect of it inside in the clinic and then outside of the clinic as well. In the public health sector, such as a community health center, for example, you can take the route of a consultant in the industry, and then of course you can also practice in the military. So I touched a little bit about an optometry residency. So what does an optometry residency actually mean? It's a specialization. It's not required, but it's a specialization. So say you go through the 4 years of optometry school and then you decide, wow, I really am interested in delving deeper into how to fit specialty contact lenses for patients who have keratoconus or graft versus host disease or some complicated corneal condition. So then you would actually want to pursue a residency that allows you to work in a setting and that will teach you how to do those specialized fittings. So an optometry residency is a postdoctoral education program centered on clinical training that results in the resident's attainment of advanced competencies in eye, vision, and healthcare. And notice when we speak about all these definitions, overall healthcare makes it into that definition. So it's very important, I want you to gain from this presentation, is that optometry is not just limited to eye care, but it actually relates to general overall healthcare. So the different types of optometry residencies are primary and ocular disease. So what does that mean? Well, ocular disease includes glaucoma, uveitis, which is inflammation of the front of the eye, cataracts, which is an age-related change, and there's a lot of co-management with ophthalmology that goes along with that. Red eyes, foreign body removal, somebody comes in with a metal piece in their eye, and if you want additional training on how to manage these sorts of conditions, then residency in primary care and ocular disease can definitely help you delve deeper into managing those types of cases. Typically in your residency, a typical, my typical resident day, for example, was rounding in the morning, and typically we did some sort of presentation style, a case presentation or something every day. In addition to that, then we had patient care that started at 7:30 in the morning, and we would see patients the entire day until about 5:30, and then we would close the clinic, round again so that we could kind of review the cases from that day. And then sometimes we would set aside time to attend fluorescein angiography conferences with associated schools in the area, like University of Maryland and Johns Hopkins at Wilmer Eye Institute. And then we were able to also have specialized clinics, for example, surgical glaucoma clinics and surgical retina clinics, where we were working with the ophthalmology residents and also the ophthalmology attendings. So optometrists in most states in the United States don't perform any surgical procedures. It's a non-surgical specialty. But there are states, and this is very state dependent, where you will be able to perform lasers and injections around the eye and cut lesions in the eye and things like that. Okay, so that all kind of falls into the primary care ocular disease umbrella. And then you've got corneal contact lenses. I touched upon that earlier. So somebody comes in with, for example, Stephen Johnson syndrome, and then you've got ocular manifestations, you need a specialized contact lens that falls under what we call scleral lenses. Okay, so what is a scleral lens? It's a huge contact lens that goes on the front of the eye. It vaults the entire cornea and helps optimize those optics so that there is a chance for visual rehabilitation. Then you've got pediatrics and vision therapy. So no specialty would be incomplete without pediatric focused care. And pediatrics also includes management of congenital disorders. So for example, those infants who are born without certain parts of their eye due to congenital disorders, or they had to have surgery from a congenital cataract or something, and then they're left without an implant in place of that cataract because the eye is still growing and you can't implant anything in the eye at that age. And so they need that rehabilitation in order for their brain to develop, in order for their visual cortex to develop. And so you can fit these infants, these 6-month-olds, with large contact lenses that are hard contact lenses. And so that is what a pediatric optometrist specialist will do. Vision therapy also falls into that. So for example, a patient comes in and they've had a TBI and they had a history of a concussion, okay, from a football injury. We all know those are very common, right? That's actually the most common cause of something called a convergence insufficiency, where the eye muscles are too weak in the focusing system, which leads to the midbrain right here. And you're actually unable to focus your eyes on one object, either here, there, or right in the center. Or you might have an nystagmus where the eye jerks, or you might have an eye turn where you need to kind of train that eye muscle to come back in. Or for example, the patient may have had strabismus surgery, which is an eye turn surgery, when they were a pediatric patient, and now they might need follow-up therapy for that. So that's what vision therapy involves. And then you've got neurovisual rehabilitation, okay? And that kind of incorporates low vision rehabilitation as well. So now we're talking about a completely different population of patients. Now we're talking about those patients who have suffered strokes and they have lost half of their visual field. So now they're unable to see out of the right eye, anything out on the right side, out of the left eye, anything on that right side. Well, they're missing all of that world on the right-hand side. So how do you move all of that world to where they can see? Okay, so there are specific instruments and devices and prescriptions that can help you do that. Another example is that you guys might know somebody, maybe a family friend, or maybe unfortunately even a family member who might have age-related macular degeneration, where they might need injections into the eye every couple months or every month. And that leaves a lot of scars and whatnot in your macula, which is the center of the vision at the back of the eye, and the patient might not be able to see very much. And so these visual rehabilitation specialists will be able to take those instruments and devices and really try to maximize the vision that the patient has left. And they work very closely with occupational therapists. And in some states, there are associations for the legally blind. And so there's a very community approach to treating these patients, and optometrists will play a very large and very vital role. So, it really depends on kind of where you want to take your career. You can, really focus on the visual rehabilitation side of things, which I would say is the cornea and the peds and the neuro rehabilitation. Or you could really focus on kind of like the diagnosis and management of ocular disease, and that would fall into the first two residencies. Okay, so a day in the life of an optometrist. So you guys did ask me to kind of cover this a little bit. Now, disclaimer, it varies by setting, and this is by no means representative of any other setting apart from, the setting that I'm in. So I am the only optometrist in a multidisciplinary, multi-specialty office. And so I'll typically work about an 8 to 9 hour work day. I see maybe 30 to 40 patients a day. And you quickly do the math and realize that you're not spending a lot of time with your patients. And you can maximize ways to do that. I have a scribe. I have somebody who helps me in the exam room doing my notations and dictations and things like that, just so that I can be spending most time with my patients. So again, really depends on the setting that you're in. I know plenty of colleagues who see patients just by themselves because they prefer to do that, and they like to see about 16 to 20 patients a day. And so I don't want you to be intimidated by this. This is just something that I've chosen, but absolutely, you can definitely have a slower pace in your clinic, and spend a lot more time with patients. And also don't forget, I am in an ocular disease setting. Now, if I were doing neuro rehabilitation consults, I would definitely need a lot more time with patients, so that we could really do all the testing necessary and try out the different devices, and really take time, especially with our geriatric patients. So what do I do? Well, I specialize really in glaucoma, medical glaucoma management. So I don't perform lasers or surgeries, but I will identify glaucoma and then initiate treatment, and then kind of follow these patients throughout their journey with glaucoma, which is a lifelong disease. And then I also am responsible for doing the diabetic eye exam. So a patient comes in, they need a comprehensive eye exam. I have blurry vision, I have dry eye. I was diagnosed with diabetes, type 2 diabetes 3 years ago. My HbA1c is through the roof. And so those patients will also come into me as well. And so I do, well, patient comes in, I check their vision. Okay, so that's the first foremost thing. Then I'm able to check the patient's glasses prescription if that's called for, if the patient is complaining about that. And I put the patient behind the microscope, and I can check the health of the front of the eye with a specific type of lens, and then I check the health of the back of the eye with another type of lens. So you have to be a very good diagnostician in order to kind of put all of these parts of the puzzle together and figure out why your patient is not seeing 20/20. I also do ancillary testing interpretation. So when I'm diagnosing glaucoma, I do want to get peripheral visual field test. I do want to measure the thickness of the RNFL, which is the retinal nerve fiber layer, which is indicated in glaucoma. And I want to look at what type of glaucoma they have. So I have to put lenses on the eyes in a procedure called a gonioscopy. And so I am responsible for also interpreting and all of that testing as well. And then, of course, refractions and contact lenses as well. And again, depending on your specialty, it might just be that you do specialty contact lens fittings all day, or you've decided not to specialize and you are doing comprehensive eye exams all day. And you would like to do glasses prescriptions, which is what a refraction is. So you can take optometry as a very large, very wide spectrum, and you can take it really in many directions. It really just depends on what your interests are. It depends on how much of that, again, disease focus you want versus how much of that focus on rehabilitation. Because you have to realize that vision is a very important sense, obviously, and it's very treasured and very precious to most people. And so there are lots of different avenues that you can pursue if you want to focus on that rehabilitation aspect of it. And an optometrist plays a really, really important role in helping patients maximize the vision that they have in advanced disease processes. So let's review some case examples, okay? So I will direct your attention to the first picture on the left. And so that's a picture of the front of the eye on the cornea. And you see these green highlighted kind of squiggles on the cornea, okay? So the cornea is the tissue on the front of the eye. And basically this patient presented with what we call herpes simplex keratitis. So this patient has a herpes simplex virus infection, and it can affect the cornea with a dendrite. Okay, so that's called a dendritic ulcer. So that's an example of how a patient can present with herpes on the eye, and then the way that you would treat that is with oral medication. It's oral acyclovir that you might remember from your biology classes. So you would do 400 mgs 5 times a day, and some doctors will choose to do topicals, and that decision varies kind of depending on which study you read. The original study supported topicals, but in clinical practice, we're kind of going away from that. So patient presents with red, painful, teary eye. It's not just red eye. Red eye is a huge umbrella. And this is one example of what a red eye could possibly be. It could be herpes sitting on the cornea. Okay, middle picture. So again, we're looking at the cornea. Okay, so in the picture, what you're seeing is lids and lashes, and then you're seeing the round brown, that's the iris, and then you're seeing the pupil, which is the smaller circle inside, and just right in front of that you're seeing kind of these brown dots. They look like brown dots. Okay, again, that's on the corneal surface, and this is actually an autosomal dominant, very rare Meesmann's corneal dystrophy. Okay, so what is that? That sounds like a lot of really complicated words. Basically, the cornea is a thin tissue on the front of the eye, and it has 5 layers. And disease can occur in any one of those 5 layers. And this corneal dystrophy, which is an inherited condition, actually causes these little vesicles, these intraepithelial microcysts right in the cornea. And so when you look under the microscope, you can isolate which layer they are in, and then look to make sure that, you know, it's happening bilaterally and in both eyes. And that indicates that this might be a corneal dystrophy. So what symptoms might this patient have? Well, it is sitting right on the cornea, which is on the front of the eye, and the lid does kind of scrape the cornea. Okay, it goes over it. So if there's a little bump and a little bump and a little bump, and it's a very bumpy surface, then the patient is going to feel that. It's going to feel like, oh, there's something in my eye. We call that a foreign body sensation. Like, I feel like there's a foreign body in my eye. Okay. And so what can happen is that the cornea will continue to erode, and then the hemidesmosomes will heal it. And then the eyelid will go over it, and it will erode again, and then it will try to heal itself. That's called a recurrent corneal erosion. Okay, that can be super painful, and it's really annoying because the patient feels like there's something in their eye, so they're constantly rubbing and they're actually making things worse. Okay, that is something that I've seen only a handful of times. It's not that common at all. And then you would treat that with certain medications, eye drops, ointments, things like that. If it was becoming very advanced, where there was developing some scarring perhaps, then that's when you would want to send over for a surgical procedure called a phototherapeutic keratectomy, which is just a fancy name for scraping. So you just want to get rid of all of those bumpy intraepithelial vesicles to create that nice smooth surface again. Okay, so third picture here on the right. So this is actually pseudo exfoliation material on the anterior lens capsule. Okay, so what you're looking at is, again, lids and lashes. You're looking at a dilated pupil. So now that iris actually looks dilated, and then you've got a large pupil right in the center. Okay, and then here you see this kind of like white line, this circumlinear, like circular white line, and it looks like it's kind of posterior. Okay, so that's sitting on the crystalline lens. So now we're talking about the middle of the eye. This is actually a systemic condition that you can tell the patient has just by looking at the front of the eye. That's called pseudo exfoliation material, and that can actually spike that eye pressure and cause glaucoma, which is something that occurs at the back of the eye. Okay, so that's actually very interesting because it's just a very perfect example of how you can have a systemic condition and you can just do a quick eye exam, and you know that that patient is at significant risk of losing his or her vision if that eye pressure is not treated. Okay, so pseudoexfoliation material can lead to pseudoexfoliation glaucoma, and that is something that I see on a weekly basis. It's very unfortunate because it's a very debilitating condition. Okay, so let's move on to a few more cases here. Okay, so on the left, you're seeing, again, patient is looking down, you've lifted the lid, and you're looking at that white part of the eye, which is called the conjunctiva, and you're seeing a metal plate. What is that metal plate? Why does the patient have metal in their eye? Okay, so this is an example. So you might look at that and think, wow, that looks really abnormal. Something looks wrong. I'm not sure what it is, but something looks wrong. And you are right. So that piece of metal is actually a mini express shunt that we used to do for glaucoma treatment. It's literally a tube with a lumen, an open lumen, and then it has a plate that has a little hole in it that's supposed to pressure, and there's supposed to be tissue that's covering it. Okay, that is not an inert foreign body. That is going to cause problems if it's not sitting in the right place and it's not covered by what it should be covered by, which is the conjunctiva. So this patient presented to me and said, hey, I had glaucoma surgery a few years ago and I haven't really seen an eye doctor, but I feel like maybe one of the sutures is loose and something's falling out. And so I take a look and that's what he has. So that is an extruded mini express shunt for glaucoma. And that was actually explanted. So it had to be completely taken out and the conjunctiva had to be sewn up. And the patient was much more comfortable. And now the patient is managed on maximal medical therapy. So no more surgeries for this patient at this time. Eye drops are working just fine. okay? So this is a really great example of how an optometrist would work in conjunction with an ophthalmologist to manage a glaucoma patient. So this patient comes in, I can see that, well, this is a problem that needs to be corrected right away because this patient is at risk for significant infection. And so we need to get this patient out to somebody who can take out the, in a proper manner, you don't just pull it out, obviously, and really kind of, suture that area back up and allow the eye to heal. And then once that surgery is done and it's explanted, that patient comes right back to me. So that's a great example of how the two kind of work together to take care of the patient. Second picture in the middle, so this might look really scary, it's really not, it's just orbital fat prolapse. So in the orbit, so you've got your eye, and then you've got a long bone, which is your bony space, which is your orbit, and then you have, your eye muscles and other things, and you have fat in there, okay? And when the fat prolapses forwards, and then you pull the eyelid down, you can, identify that, and if it's growing or becoming problematic, then you would want a CT of the orbit to really visualize what's going on in there. And you might even need to co-manage that with ENT as well. So another example of how you would co-manage a problem in the orbit with an outside non-eye specialist. And then the last picture is just another corneal dystrophy. So I talked about the 5 layers of the cornea, which is the tissue in the front of the eye. So this is a disorder of the middle layer. So the Meesman's dystrophy was right at the front, and this is the middle layer, right in the middle, called the stroma, okay? And so you get these granular deposits that look like breadcrumbs, and they are typically, you would think, wow, the patient might not see very well. And it's actually quite interesting, but patients don't really have visual problems from these huge breadcrumb looking lesions on the cornea. But again, if they accumulate to the point that they're now, so pushed forwards anteriorly that they're breaking through the epithelium and creating that erosion again, then again, you would just go in and scrape it. And that would be done, with the cornea specialist, and then they just come back to you for further management. But typically, corneal dystrophy, granular corneal dystrophy is not a problem. So now we're shifting gears, and we're looking at the back of the eye. Okay, so I want you to focus your attention to the image on the right, because that is what normal looks like. So an ocular coherence tomography is basically a cross-section of the retinal layers at the back of the eye. So it's pretty amazing that we have this type of technology that can allow us to identify disease in all 9 layers of retina. Okay, so technology in the eye world is really progressing and just taking off. And this has really changed the face of diabetic management and hypertensive management, and monitoring certain medications like hydroxychloroquine. I'm sure you've all heard that now because of COVID, which is a medication that's usually is used usually to treat systemic lupus erythematosus and or lupus, and it can cause toxicity at the back of the eye, and it will show up on a scan like this. And so you want to notice just kind of how flat all retinal layers are stacked on top of each other. So those are the horizontal white and gray lines. And then you want to notice how there's like a little bit of a U dip in the middle. That's the absolute center of your vision, and that's called the fovea. Okay, so that's where your 20/20 central vision comes from. And you want it to have that little U-shaped dip, okay? Now focus your attention to the image on the left, and you're thinking, well, that's the complete opposite. That does not look, something looks off, and you are correct. And if you can look right at on the black space on the top of the image, there's a black space, okay? And what you can see is kind of like a thin line that looks kind of like bird wings, okay? So it kind of looks like this. And the focal adhesive point, the adhesion, is right in the center, and it seems to be tugging right on that macula, okay? So that is called vitreomacular traction, and that can really cause significant vision loss for the patient. It's not permanent vision loss, depending on how long it's been there, because a lot of times this will spontaneously just detach. So that kind of like that, the M, okay, the McDonald's sign kind of, okay, right in the middle, that will just boop, detach, and then the retina will lay flat back down, okay? This patient's vision was one line away from perfect 20/20. You might look at that and think, oh my goodness, that looks absolutely terrible. But actually, the patient was seeing really close to 20/20. And out in the real world, what does that mean? Nothing. You can still see everything you need to see at 20/25 vision, okay? And you can still drive at every state. And so if this has been there for a long time and that tugging continues, then that can be a problem, because actually it can take that layer of retina with it, and it can cause a full thickness macular hole. And now we are in trouble, because now we need a surgical procedure to lay all of that stuff back down, okay? Another great example of how you can manage this as an optometrist in your clinic, 20/25 vision, monitor every 3 months, tell the patient to monitor their central vision, and there are, devices and things that can help you do that. And at any sign, the first sign that things are changing, that might mean that that focal adhesion is taking more than it should, and now you might be a surgical candidate, okay? So it's actually really neat technology that we have available to us, and we can manage so many conditions much more effectively than we used to be able to. Okay, glaucoma, this is my baby, I love it. So glaucoma is unfortunately a very visually debilitating disease in all seriousness, okay? So you may have heard of glaucoma. Let's just start with a quick definition. So cranial nerve number 2 is the optic nerve, which is located back of the eye. So it starts at the back of the eye, and then it projects, into the brain, okay? And you can see a cross-section of the optic nerve when you look at the back of the eye. And there are certain conditions that can tell you what's going on in the brain. For example, if you have increased cranial pressure, okay, that can manifest because the fluid will then surround the optic nerve sheath and then create damage to the cross section of the optic nerve and really tell you what's going on in the brain. So, it kind of goes back to that point I was making before, where your systemic health can be disclosed by the health of the back of the eye. So glaucoma is actually a disease of the optic nerve, okay? So it's not anything to do with the brain. So it's when the eye pressure inside the eye is too high, all right? So I want you to think of a container. I want you to think of inflow, and I want you to think of outflow. And you have to maintain a certain level of volume, okay? So if you have either you're making too much fluid in the eye, or you're not releasing enough fluid in the eye, well, the volume is going to increase and your pressure is going to increase. So your pressure increases, it creates a compressive force to the optic nerve at the back of the eye, a translational compressive force to the back of the eye, and it starts crushing some of those very important axons that help you see the world. That's your central vision, your peripheral vision, okay? So when that happens, then you have to control the eye pressure. And the way that you do that is by targeting those two mechanisms. You either decrease your production or you increase your outflow. And we have certain medications that help us do that. We have lasers that help us do that. And then finally, we have surgery that helps us do that. Your first line is an eye drop, and we've got probably about 7 different eye drops that target different receptors on the front of the eye that will either allow for suppression of inflow or increase of outflow. And then if none of those work, and then you can use them in different combinations. And if none of those work, then you do have to move on to laser and surgery and other things, okay? So glaucoma can be very visually debilitating because it does take away your side vision first, and it's irreversible vision loss. It's very, very, very important that an optometrist is dilating the back of the eyes so that he or she can identify the health of the nerve, assess the health of the nerve, and diagnose glaucoma, and then start treatment if necessary. Okay, so we did touch a little bit about medications and side effects and how they can affect the eye with the hydroxychloroquine for lupus. So on the left-hand side, you're seeing another corneal picture. And this is really nice because you can kind of see almost like a brown branch looking pattern on the front of the eye. And that's called corneal verticillata, or another word for it is whirl keratopathy, like a whirl, okay? And this is actually a side effect of a calcium channel blocker, which you might recall from some of your pharm classes, called amiodarone. And is typically used to treat cardiac arrhythmias or dysrhythmias. And so it's typically non-visually significant. You don't have to scrape the cornea. You don't have to do anything. And basically what it is some of those metabolites are just depositing onto the cornea on the front of the eye. You don't stop the medication in this case, but it's something that the optometrist, when they do the exam, they can see and you know, have a medication list. And if you don't have a medication list, you can say, hey, I see well keratopathy on your cornea. Are you by any chance taking amiodarone and all these other medications that possibly might cause this? And then you just, you know, you watch it and you communicate with the cardiologist and you let them know that, hey, you know, there is some well keratopathy on the front of the eye. I'm not worried about it. It's not affecting the vision, and you can just continue with your treatment. Okay. So it's just another really perfect example of how the optometrist will communicate with other non-eye specialists. And then on the right-hand side here, we have an example of age-related macular degeneration. So right in the center, so you've got your optic nerve, we talked about that, and then you've got these red lines, that's your vasculature, your arterioles and your venules. And then right bang smack in the middle of that picture, you've got a red hemorrhage, okay? So you've got this nice circular red hemorrhage, and that is basically a manifestation of wet macular degeneration, which means that there's bleeding coming from underneath the retina and now kind of seeping through those 9 layers of retina. And it needs to be referred to a retina ophthalmologist who can then do an injection into the eye to absorb that blood. So if this is something that you see as an optometrist, then you've got about a week to get that referral out. Prognosis will decrease the more time that that blood sits there. And then, of course, you have to monitor the other eye and things like that. And that's something that I see very often because I work in a retina clinic. This can be very debilitating for patients, unfortunately. Most patients don't do very well when they do have to have injections. It also is a commitment because it's essentially one injection every month or every 3 months for the rest of their lives. So they need a lot of support. They definitely need visual rehabilitation with low vision devices that we talked about earlier, really good pair of glasses, reading glasses, things like that. Not only does the central vision decrease, but they can't see colors very well. And so this can be really quite horrifying for some patients. They might get their driver's licenses taken away. It really decreases their independence, and it's a really horrible condition to have to manage for the doctor and then also to live with as the patient. So this is one of the last cases, I think. So on the picture on the left, that's the patient's right eye, and the picture on the right, that's the patient's left eye. That's typically how you would position your images. And they look really different, guys, right? Okay. So the picture on the right, you're thinking there's a huge yellow, bright, shining light. That looks not very good. What's going on there? Okay. So this is a patient who presented to me. She had a history of stage 4 metastatic liver cancer that had metastasized to the choroid in the left eye. So that's the image on the right with the big yellow lesion. Okay. And so the choroid is the tissue that's underneath the retina and that provides a lot of blood supply to the retina. So she was referred out, and so I referred her out, and she was able to get treatment, which was in the form of plaque radiation. So you go in, literally, you know, do the plaque radiation. And then she was doing well for about a year and a half. I mean, she had a visual field defect. She was about 3 or 4 lines away from 20/20, despite that huge out there. We were managing with the oncologist, and she was doing really, really well. And then she comes in and she says, hey, Dr. Kataria, you know, I've noticed that my left eye doesn't see so well at nighttime, but during the day, you know, I'm pretty much okay. Could you just check it out and just, you know, let me know kind of what's going on? I'm a little bit worried, especially because of all the treatment that I've had in the left eye. So I said, yeah, absolutely. Let's take a look. So what you can see on the optic nerve is that the optic nerve look very blurry. It doesn't look like a very distinct circle. And if you follow the optic nerve superiorly, you see this kind of like white fluffy lesion, okay? So all these together, what they represent is an inflammation of the optic nerve. It's called radiation optic neuropathy. It's very rare. It's barely reported in the literature. The literature really just supports that you observe this until the vision decreases. And if the vision does decrease because of this from baseline, which hers was, you know, a couple lines away from 20/20, then again, you would inject the eye with a certain medication that can help absorb some of those inflammatory mediators. And so this was, something that was very worrying, obviously, first to diagnose this metastatic lesion at the back of the eye, and then also to find that a year and a half later, she's actually not doing as well as she thought she was doing. And why does that happen? Well, the radiation that's delivered to the back of the eye can weaken some of the vasculature, the endothelium of the vasculature, and then some of those guys can start leaking and bleeding, and then that's starts the inflammatory cascade, and that's why it presents that way, and can decrease vision and things like that. So this was something that was pretty scary for the patient, but thankfully she was very astute, and she's actually not even that old. She's 50 something. So she's actually quite young, and living with this and dealing with this, she's been through a lot. And I was just so happy to see her so that we could make sure that she was in the right hands with this case. And then, of course, diabetic retinopathy. So again, very similar, a disease process that affects the parasites in the endothelium of the vasculature, weakens the vasculature. Because of the high blood glucose, the vessels start leaking. And so, you can see pictures here of these abnormal red blood vessels on the optic nerve. And this is neovascularization. The back of the eye detects that it doesn't have enough oxygen because of the high blood glucose and the chronic damage over time. So there's an impetus to grow more blood vessels to compensate for the lack of oxygen at the back of the eye. And while these blood vessels are very well-meaning, if you want to personify them, they're actually not very good for the eye. They cause a lot of havoc at the back of the eye. They grow in places they're not supposed to. They pull on tissues they're not supposed to, and they can cause permanent loss, and then they can cause scarring and things like that. And so the bottom two pictures, the black and white, what we're seeing is a fluorescein angiography. What that means is that we inject the fluorescein intravenously, and then just like the dye kind of travels through the vessels, and then you can take pictures within a couple seconds of the administering the dye, and then you're able to see these leaky, friable, very fragile, well-meaning blood vessels that are causing havoc. And when you do lasers and injections, these are the guys that you want to target, because they are not very healthy. Despite the fact that they are well-meaning, they're actually not very healthy, and can cause a lot of problems. And unfortunately, they are an indicator of the disease process that is advancing. Okay. And then the retina, obviously, you're thinking, well, what are these little bear track lesions? You see kind of these burn marks that kind of look, black on the fluorescein angiography and look a little bit gray or green on the color photos. And that's laser. So you actually can laser the back of the eye. So that won't be done by an optometrist, by a retina ophthalmologist. And once that laser is put down, it actually decreases the oxygen load in that area, and therefore it can decrease the impetus for these new blood vessels, so that the eye doesn't detect that it's deprived of oxygen. And it's hypoxic, it's not anoxic. Okay. So I am wrapping up here, Nina. So we kind of talked about optometry, and is medical optometry different? Because it's, something that I really focus on in my career path. And medical optometry is not different than optometry in terms of how you get there. Okay, you still would pursue optometry school and the residency and the fellowship, but simply it's just a focus on medical management and niche of optometry. Okay, full scope optometry refers to the preference to practice to the highest level that your state regulation allows. And just like with every profession out there, there is, political debate, and there is red tape about what an optometrist can do in which state and things like that. And there are states where, like I mentioned before, optometrists can do lasers in the eye and injections around the eye and suturing and things like that. So full scope optometry will refer to that. Medical optometry includes management of diabetic retinopathy, glaucoma, cataracts, uveitis, red eye, foreign body, sorry for that typo, foreign body in the eye, and infections. Okay, so a patient comes in with a red eye. That's something that's completely in my wheelhouse. I'm very comfortable managing that, where I can do diagnostic testing to figure out, is this an infection on the front of the eye? Is it an inflammation at the back of the eye? And my residency in ocular disease and my fellowship have trained me, provided me with clinical didactic experience, so that I can manage these conditions. And then again, residency and fellowship, I highly value, if you have not already gathered that, but it's helpful, it's optional, it's definitely not required. Can you get to that same level, that high level of practicing medical optometry without a residency and a fellowship? Yes, absolutely you can. It really depends on where you are employed, and who you're working with, and what your patient base is, and your experience, and then of course your motivation as well. Okay, so that plays a huge role. So just to kind of wrap up, optometry has a wide spectrum scope. It ranges anything from I want to do glasses and contact lenses all day, and I'm really happy with that, to I want to be able to manage all the things that I talked about in my talk today. Full scope medical care usually involves some sort of co-management with ophthalmology, who are surgical specialists in the eye care world, whereas optometrists are the primary care eye providers. The political climate is changing as optometry advocates for more medical and laser procedures around the country. We're definitely making a lot of strides when it comes to that. Optometrists tend to co-manage with internal medicine, family medicine, endocrinology, especially for diabetics, autoimmune diseases with rheumatologists. That's something that, as I kind of delve more into dry eye and develop that advanced dry eye clinic, I'm finding myself co-managing with rheumatologists and with patients who have Sjogren's syndrome. Neurology, ENT, allergist, cardiology. So, I kind of touched upon most of those. Many specialties such as vision therapy, neurovisual rehabilitation, they require a really in-depth understanding of the visual cortex and the cortical functions. And so that's just really to illustrate that you can pursue many different avenues of optometry. So what recommendations do I have for pre-health or pre-optometry students? Okay, so the first and foremost, if there's only one thing that you do, is that you must shadow in various settings. Don't just pick one, pick a few. I would highly recommend that. And I wish somebody had told me that before going into optometry, so I understood where and how I could practice. I went into optometry school with the idea that I was going to pursue a residency at the VA and that I was going to be a medical optometrist for the VA. Okay. Now I'm a medical optometrist, but in private practice. But the idea is that I would tell my younger self that, if you are interested in optometry, then shadow an optometrist in a corporate retail setting, shadow an optometrist in a private practice setting, and then shadow an optometrist in an ophthalmology medical hospital type setting. And then you can really understand truly where that spectrum lies and kind of where your interest lies, if you are still interested in it at all. And then for high school students, you want to do well on the SAT, ACT, and then again, accumulate your shadowing experience. For your undergraduate, as you're preparing as an undergraduate, how can you strengthen your application for optometry school? Well, you do have an optometry admissions test that you must take, like most professional schools, like dental school, medical school, etc. Your science GPA will be weighed, not super heavily, but it will be weighed. So, if there are classes that you don't really care about, don't choose that class to be like physics or organic chemistry. You still have to try. Not my favorite classes, but seriously, you have to try. And then you do have the typical science requirements for any pre-health track. So you've got, your biologies 1 and 2, organic chemistry 1 and 2, calculus 1, 2, et cetera, et cetera. And so that's not really any different. And then when you're in optometry school, okay, so, well, what are my tips for succeeding in optometry school? Well, first and foremost, take every opportunity you can to volunteer, in screenings and research. I really tried to focus on, I did some research with the National Eye Institute during my first and second year in the summer. So I stayed on campus and did a bit of that. And then, I was really able to take advantage of all the screening opportunities that are available. Build a network of seniors. When you get out of school, you will need doctors to reach out to. Hey, can you tell me, what do you think about my practicing in X setting? And can you review this contract with me? Things like that. How much should I be getting paid? So you really want to build your network. Shadow, study for your national board, practice your clinical skills as much as possible in the labs, as it is a huge section. It's 33% of the board exam is actually to be able to perform an eye exam correctly. And so, you definitely want to take as many opportunities as you can to do that. And please feel free to write to me with any questions. This is my Instagram handle. You can always write to me. No question is a stupid question. If you're thinking that, please don't be intimidated. And I'm very thankful and grateful that you guys have this opportunity to kind of do a shadowing session in COVID times. I think you guys are doing a great job. And just one piece of motivational advice: just don't let anyone tell you you can't do it. They're not in your shoes. You know you can do it. You fill your own shoes. Okay. And then we kind of talked about this as well, right? A few words about my personal journey, just shadow. If you are interested in the eye world, you have to think about, does surgery appeal to you? If you're interested in cataract surgery or different types of surgery, eye muscle surgery, things like that, then maybe optometry is not for you. Maybe ophthalmology is for you. Okay. So ophthalmology gives you, a nice balance between like your surgical aspect and your clinical aspect as well, but the focus is on surgery. And then, what kind of lifestyle are you looking for? And you can choose that in optometry too. If you don't want to be on call, don't go into a practice like I am in, where you have to share the call with the other doctors in the practice. But do optometrists take call? Yes, absolutely. It just depends on what setting you're in. So you can set that up for yourself kind of as you do your research and you shadow and things like that. And again, I would highly consider anyone going into optometry school to go in with the thought process that you would consider a residency. I think it's invaluable experience. And really, if you're lucky enough and your stars all align to find a good mentor out of optometry school, then perhaps you'd be afforded the opportunity to manage very complex cases. Otherwise, I think a residency is definitely the right way to go. And I would advocate for that for anybody. Okay, that is the end of my presentation.
Thank you so much for such an informative presentation. It was amazing. And we'll go ahead and jump right into the Q&A if you're ready for it.
Okay, yes, let's go ahead.
Okay, perfect. Our first question from a student is, what do you do when you encounter something that you do not recognize or are not sure how to treat?
That's a great question. So that's where your network comes in. So when you are a independent optometrist, let's say that you have a private practice and you're just looking at this lesion, you're thinking, oh my goodness, I have no idea what that is. Okay. The retina specialist down the road, you can call them up if you have that type of relationship. I've done that many times. I'll send a picture and say, hey, what do you think? Can you see this patient today? So you would really want to refer out. That also happens sometimes between optometrists. So for example, I'm not
Thank you. The next question is, what was your first complex case and how did you approach it?
My first complex case, my first complex case was a teenager. She was a teenager. Oh my goodness, bringing back memories. So this was a patient who had thyroid eye disease. So she came in for her exam, said, I'm having some double vision. And when eye doctors hear double vision, they think, okay, it's just blurry. I'm so sorry to admit, but sometimes we can be a little bit dismissive because a lot of people don't really know what double vision truly means. And so I remember thinking, okay, so she's probably having some blurry vision. I'll just go through the exam. And I totally underestimated the case. So thyroid eye disease can cause multiple types of double vision because it can cause a paralysis of different eye muscles. And so I was going through the exam and I was thinking, I'm so frustrated, things don't add up. And I thought to myself, I really need to get a CT to see what's going on in the orbit because something is just not working here. And so it was instinct. Okay. I was very young. I was just out of residency. I didn't have my attendings to lean on to tell me what to do. And my friends looked up to me for advice. So I was very nervous. And so I actually ordered a CT and I sent the patient to a neurologist down the road. And I called them and I said, hey, I have this patient. I'm not entirely sure what's happening. I think either she might have thyroid. I think she might have myasthenia, but she's really young. And so we kind of talked about the case a little bit. I sent her over, and it turned out that she had thyroid eye disease. And so she was treated with the neurologist for her thyroid, and also with endocrinology.
Thank you so much. Our next question is, did you consider any other specialties before settling on optometry? And if so, what were they?
Yes, I considered ophthalmology. So in high school, I was very excited about eyes. And I just really loved the idea of being a specialist of a very tiny but mighty organ. And it's obviously very important. And so as I was kind of doing my shadowing experience, I realized that I wasn't very interested in surgery. Not that I couldn't do it, but it just didn't excite me as much as helping someone, helping someone see with a device or an implant. And actually, I wasn't even interested in medical ocular disease. I was interested in low vision, because I was very passionate about trying to help patients come out of their decreased vision, because it can be so debilitating, like with macular degeneration and things like that. And then as I went through optometry school, I was like, oh, well, actually, the VA produces a lot more opportunities for me, and I can really get my teeth into the ocular disease side of things. And that's how that developed.
Interesting. Thank you. The next question is, did you get a chance to study some rare eye disorders in the optometry school? And if so, are there elective courses that focus around rare conditions?
Yes, absolutely. Retinal dystrophies, you get all of that education, it's tested on boards, and there are opportunities to choose electives, clinical electives. And mine were, interestingly enough, peds. And that's when I realized that peds is not for me. So we had a core class and lab that was peds, and then we had a specialized peds elective, and then specialty contact lenses was another one, and then low vision.
Optometry school, are there classes on different eye drops and their biochemical effect on different diseases and infections?
Yes, definitely. You get the education on pharmacology. And so we actually had a guest lecturer come in, and he was an internal medicine doctor. And so we had an entire 2 semesters on pharmacology and biochemistry. And then, of course, you do take biochemistry in undergrad as well.
Thank you. The next question is, will some schools take the MCAT or DAT rather than the OAT?
For optometry school? So optometry school only requires the OAT. So they will not look at DAT or the MCAT. You would have to take the test separately.
Thank you. How has COVID affected your day-to-day life as an optometrist?
Great question. So with the initial shutdown back in March, April time, patients were not coming in, and it was very slow. As things started, we never closed our clinic. We were always available for eye emergencies. And so during that time, I saw a lot of vision loss cases. Patient presented, she had had a recent stroke. I had to send her to the stroke center that was locally in my area, which was very scary because of the COVID cases, but we had to send her there for platelet therapy. And a patient came in with acute vision loss, and he was having an ocular migraine. Another patient came in with a retinal detachment. They had to have surgery. My retina specialist had to really fight with the hospital to try and get the permission to perform the retina surgery, because they were not allowed. They were thinking it was an elective surgery, which is like cataract surgery, and it's not. And we really needed to do the surgery for the patient. So we were seeing a lot of emergency type cases. We saw a phacolytic glaucoma case where the crystalline lens was leaking and the patient needed to have that lens taken out. And so that was the initial stage. And then as things opened up, patients felt safer coming in. We've obviously, wearing our masks and our N95 masks and our other PPE, our eye safety glasses and things like that, gloves and gowns for procedures. So now we've been extremely busy because all of that surge from before, where patients were not coming in, and a lot of patients with advanced glaucoma who really did need to come in chose not to, and we're really backtracking on a lot of those patients.
Thank you. The next question is, which residency would you recommend if you want to focus on patient interaction?
I would say that all of them will focus on patient interaction. You have to interact with the patient if you're looking at their eyes and treating their disease or fitting their contact lenses. For the more rehabilitative residencies, you're spending sometimes more than an hour with a patient a day at every visit because it's so complex. And so you really have to be comfortable interacting with patients and showing compassion and patience.
Thank you. Next, we have a little bit of a fun question, and that's, what's your favorite part of your profession?
I love learning from patients. I have met the most interesting people, I feel. And I just love like sitting and listening to their stories. And I mean, sometimes, you get really involved and it can be, you're showing a lot of empathy because you really feel that for the patient. You get really carried away, but I just love getting to know their grandkids and their kids, and they come in and they say hello, and we have a little introduction, and I learn a little bit about their life, about what types of parties they're throwing their grandchildren. So that aspect of patient care is really attractive to me, and it never gets old.
Thank you. To dive deeper into that question, have you ever treated any famous athletes or actors in Los Angeles?
I have not, actually. I'm not my practice is not very close to any of those areas like Calabasas or Hollywood or Beverly Hills. So maybe one day, I don't know.
Thank you. Next, what characteristics do you think make a good, successful optometrist?
Well, you first have to be very motivated. And you have to be very compassionate because you are a healthcare provider and you're going to be dealing with patients every day. If you don't like to talk or interact with patients, then it's something to reconsider very seriously. Because you're spending a lot of time with the patients. Eye exams take a long time, minimum of 20, 30 minutes. And so those are, I think, motivation and compassion are the two biggest things that I would say.
Thank you. The next question is, what was the hardest part of getting into optometry school?
I think it's just the competitive nature of these professional schools, that you feel like you have to be doing research and, you have to be volunteering and taking every opportunity that comes your way. And so my preparation for optometry school looked a lot like med school because I was kind of going down that path. And so I was doing research 30 hours a week, which was putting a lot of strain on me mentally and my time wise. And then I was volunteering. I was very active in certain associations, and albeit a lot of, kind of pre-health students will follow that same track until they figure out which avenue they want to take. And I think the biggest, piece of advice I would say, looking back on the whole thing, is that you don't have to do everything. Pick and choose a few things that you can do and show commitment to it. Do it for as long as you can. So if you start something in your freshman year, my biggest advice is that what they really love, what they really look out for is, can you stick with it? Not that you've done 100 different things and only got your feet wet in it.
Thank you so much. Next, we have a question that's, do you feel like you get a good balance between your work life?
Did Barbara freeze for anybody else?
Okay. I'm sorry. I'll take over. So the next question is, can glaucoma be prevented?
Do you want me to answer Barbara's question about life-work balance?
Okay, sure. Go ahead.
Okay. You froze, Barbara, so we couldn't hear you for a while.
I'm back now. Hopefully it won't happen.
Yeah. I find that I have a really good balance. I think a lot of that is up to you. In residency, it was obviously a lot more demanding because you're studying for state boards and national boards, and you've got presentations and grand rounds and things like that. So it's definitely a lot more difficult. But in work, now that I'm out, I feel that I work very hard to maintain work-life fit by working out, by doing headspace meditation, spending time with my family, reading, taking up hobbies, things like that. So it's definitely possible. Maybe in training, not so much, but once you're out, you can make it, kind of what you want. And then, is glaucoma preventable? Excuse me. Glaucoma, you can treat. You can't necessarily, you can prevent progression. You can't prevent somebody from becoming a suspect. If you're a suspect, it's because of your genetics. It's because of maybe something to do with your systemic disease, like high blood pressure or low blood pressure, and then compressive forces on the eye. So prophylactically, you can't really prevent somebody from becoming a glaucoma suspect. Once you've identified, you can prevent disease from occurring. So that's called treatment, but you can't cure it either.
Thank you so much. Next, did you partake in any pre-optometry health internships? And if so, do you recommend these for students?
Yes, I started a pre-optometry internship at the VA that was opposite my undergraduate school. And so I do recommend that you either partake or you start one if you don't have one. You get a few students together and try to get that going, or you take it upon yourself to shadow in different settings.
Thank you. The next question is, due to COVID, it has been increasingly difficult to find shadowing opportunities. Do you have any advice for pre-optometry students?
Yeah, I do. I actually had a couple students reach out to me on Instagram asking me the same question. And so I referred them over to you guys. I think this is a really great opportunity. To get real life experience, you have to reach out individually to optometrists in your area and introduce yourself and ask if there's a day where you could come in where maybe it's a little bit slower, things are a little bit more spread out. My advice is that if you are serious about doing that, start reaching out in the new year. Optometrists are very, very busy right now because of flex spending and people having met their deductibles, so they're trying to take advantage of the services and things like that. So optometrists might not necessarily be willing to do that now, but in the new year, things will slow down for everybody. And so reach out, introduce yourself, let them know what your goal is, and ask them if they'd be willing to have you a couple hours a week.
Thank you. What are the major differences between optometry and ophthalmology?
The biggest one is surgery.
First of all, thank you for referring students to our program. And the next question is, what are some resources you would recommend for pre-optometry students interested in learning more about the profession and exploring potential goals they may want to strive towards throughout their journey?
So I think your state association is a really good place to start. So for me, that would be, or for students in California, that would be the California Optometric Association. And then on a national level, the American Optometric Association is a really good place too.
Thank you so much. Next, what are some major difficulties, if any, that you have faced in your field?
I think that the difficulties that optometry faces are not very different than any other profession, really, or any other specialty. There's a lot of, politics that are involved with state regulations. Can you treat this? Can you treat that? Should you be able to prescribe an oral medication? Should you be able to do laser? Does your training prepare you to treat X type of patient? And a lot of that is just turf war. Okay, so it's just, I want to be able to do this versus I want to be able to do this, and I have a bigger pocket, so I can feed the politician more to get this bill passed, and that's really it. So that's been the biggest challenge, I think, just in optometry as a whole, in kind of promoting that optometry is the first line eye care provider, and that ophthalmology is more of a surgical specialty. And then the second thing that personally I had difficulty was finding the right fit for me. So I did explore lots of different options, even when I graduated residency, to figure out where I wanted to be long term. And so that took a few years for me to figure out. And guys, that's okay. It's okay if it takes a little bit of time for you to figure out what you want to do. You're in it for the long run, so take your time and fulfill your process.
Thank you. The next question is, by what mechanism do diabetics lose their vision?
So you, as a diabetic, you have an increased blood glucose, which causes damage on the endothelium of the vasculature at the back of the eye. And so when the endothelium starts to break down, then the blood vessels start to leak, and they can start leaking right into the center of the vision. And if they're leaking into the center of the vision, then they're causing disorganization. Organization in the eye tissues is very, very important for clear vision. The tissues need to be organized in the way that they were intended. And if there's a disorganization because there's a hemorrhage that shouldn't be there, then it can compromise the way that light converges to that central vision point at the back of the eye.
Thank you. Next, for a patient or for the patient with radiation optic neuropathy, what was the treatment?
So for that particular patient, when she developed radiation optic neuropathy, her vision was still baseline vision. So the treatment was to observe, but very, very closely. And at that first, because in the literature, the literature doesn't really support treating that patient with an intravitreal, which is an injection that goes into the eye. But had the vision been much worse, then you would send that to a retina specialist, and that retina specialist would be able to do an injection to absorb the inflammation.
Thank you. The next question is, in what ways has the field of optometry progressed over the years, and have there been any breakthroughs in the past few years for the treatments of certain eye diseases?
That's a great question. Yes, 100%, absolutely. So even from when I graduated in 2012, the state of Florida, for example, has gained the ability to prescribe certain oral medications that they could not prescribe previously. And then certain states have gained the ability to perform laser procedures. In California, there is a new cataract implant called the light adjustable lens, LAL, and optometrists are able to perform the laser, which is the only laser of its kind and the only laser that they can perform in this state because of all the red tape. And so optometrists can perform that laser to adjust the lens, the light adjustable lens. So to answer the question in short, optometry as a profession is making huge strides. Your state association and then the National American Optometric Association are the entities that will advocate at the government level for that.
Thank you. That is super interesting to hear about. Next, how did you choose where you currently practice optometry?
So I was practicing at various settings before this, and I was looking to kind of find something that was more medical based, and so I interviewed with an ophthalmologist who basically was like, we want to have you here, but I don't think that you'd be challenged enough. Why don't you chat with this ophthalmologist who's just down the street from me? And he happens to be my good friend, and that's kind of how we connected. So that was really through word of mouth and through networking.
Thank you. The next question is, in high school and when transitioning to undergrad, what are a few ways to earn volunteer experience?
That was through shadowing.
Thank you. Next, can diabetes do neurovisual rehab as well?
Can diabetes do neurovisual rehab?
Sorry. Can diabetics do neurovisual rehab as well?
Oh, okay. So if you have permanent vision loss in the center of your vision from diabetes, then you have a loss of vision that needs to be rehabilitated. So yes.
Thank you. Sorry about that. The next question is, what major factors affected your decision when choosing which optometry school to attend to earn your OD degree?
That's a great question. I was living in Florida at the time, and I was really interested in going to Berkeley for optometry school. And that was like my only dream in life, was to go to Berkeley. And so I applied to the Florida school, and I applied to a school in Boston, and I applied to Berkeley. And so I interviewed at the Florida school and at the school in Boston because I just needed a third choice. So I just chose Boston. And I had to wait a few months because of the interview, the way that the interview was structured at Berkeley. So I interviewed at Nova in South Florida, and then I interviewed at Boston, and I was like so wowed by the clinical experiences that the program offers and just how early they implement that into the curriculum. And when I was comparing the different schools, and I also interviewed at SUNY in New York, those were my four choices. It was really important to me to kind of, figure out where I wanted to live. And my family was on the East Coast, so geography was one of them. And then the curriculum was also really important. When I was choosing a program, I wanted to focus on having clinical experience a lot earlier than the traditional third year. And my program was able to implement that in the first year. And so my second week of school, I was already doing vision screenings for the public school system, which was amazing. And so I was already in there kind of applying all the clinical skills that I had learned. And by the time I got to my third year, I was so proficient at all those skills that I could focus on other things. And so that was one of the really major deciding factors. And then, of course, I fell in love with Boston as a city. And then I really loved the facilities. And so we were a small campus, but the facilities were really nice, and I really felt like it was something a place where I could thrive. And so I would say that geographical location is really important. And then when you go and do your interview, you have to think, well, can I actually see myself living here? Is this, I'm going to be here by myself. Is this something that I would enjoy? And I fell in love with Boston itself. And so Berkeley just kind of went by the wayside.
Well, thank you very much for this session. We want to wrap up with, do you have any final advice for any pre-optometry students or any pre-health students in general?
I would just say that, I think you guys are in a very unique situation because of COVID. And I think the more exposure, even if you can't physically shadow, the more exposure that you get to folks, with boots on the ground, like myself and the other doctors that you are listening to talk, really, really listen to what they're saying about their lifestyle, about what they manage every day, and really try to put yourself in their shoes and think to yourself, am I really interested in looking at people's eyeballs all day? Is that something, do I really want to look into people's mouths all day? Do I really want to examine feet all day? You really want to try to imagine yourself in that world before you make a decision. It's a big decision, and you should take your time to make it. And the way that you do that is you start as early as possible. And then the second thing I would say is just really don't let anybody tell you that you can't do it. And that's it.
Great. Well, thank you so much, Dr. Kataria. That was an amazing session. And we're so honored to have professionals like you who are truly trying to give back to the next generation, as we, like how you said, are living through such a unique time. We are, the first few batches of pre-health students who are applying to these health programs under these conditions. And so, we're setting the stage for the preceding years. And so I want to draw my students' attention to our presentation over here. I do encourage all of our students to be having some reflection time after each session, as these are monumental parts of our applications when we are potentially applying to these various health programs. And so while these are not mandatory, I do encourage it. There are 3 questions that I have for you here. I recommend perhaps having a notebook or a Google Docs file that you can refer to and keep track and organize all of your reflections. So it'll definitely facilitate the writing process for you when you get to that stage. For everybody that is in our virtual shadowing session here today, I will go over the quiz at the end of this presentation. For now, I want to show you this QR code, and this is actually a different code than I showed at the beginning of the virtual shadowing session today. This is to join our fundraising team rather than to donate. So we're not asking you guys to send us any money. We are actually just asking you to send this out to 5 other people. So if everybody in this live session is able to send this link to 5 other people tonight, we can potentially raise enough money to keep our website up for 3 months. And that's amazing. This is, again, a student-led nonprofit organization that provides free virtual shadowing opportunities for our students. And so we ask that as we provide these opportunities for you, please help us keep our program free and accessible to all students as we work to fight inequity in health education and to promote diversity in the various health fields. Thank you, guys.
Wonderful. Okay, thanks for having me.
Thank you so much, Dr. Kataria. Have a nice
Am I okay to sign off?
Yes, you're all good. Thank you so much.
Okay, great. Okay, bye, guys. Thank you. Have a great night.
So for all of you who are interested in becoming a member of our student team, we are taking applications. This is great because it is a 100% remote, COVID-friendly opportunity where you have the opportunity to meet with like-minded students, gain leadership skills and other professional skills that will benefit you in your future endeavors. So you guys can sign up on our website or by scanning this QR code. We understand that even though it is currently winter break and many of us are not in classes, that we are still super duper busy. And so if you guys still want to get involved with pre-health shadowing, but may not have a lot of time to commit on a weekly basis, we also have volunteer opportunities available. This is 100% remote, and you get to work as many or as few hours as you would like. So if the only time you have is at 2 in the morning, you are more than welcome to help us out at 2 in the morning. You guys can sign up to become a volunteer on our website or by scanning this QR code. To stay updated with the upcoming virtual shadowing sessions, be sure to follow us on Instagram. I have a challenge for you all today, and that is to head over to our Instagram and find Dr. Kataria's post. Under her post, if you comment her last name letter by letter, you have the opportunity to be the student of the session. It's very hard with the Instagram algorithm, so good luck, everyone. Last announcement is to be sure to tag us in your posts on social media at pre-health shadowing and use the hashtag pre-health shadowing for an opportunity to get reposted on the official pre-health shadowing account. Like I said earlier, this is not a secret. We really want to allow every pre-health student know of this opportunity. So even if they decide not to participate, they still had that opportunity to potentially grow in their fields of interest. Our upcoming shadowing session next week, we have a dentist. So if you guys are interested in the dentistry route, be sure to check in at 4:30 p.m. Pacific Standard Time. And finally, to take the post-shadowing assessment to get your certificate that verifies your virtual shadowing hours today, you are going to head over to the speaker's link. And on the website, there will be this free Take This Course button. When you tick that button, you are going to have 30 minutes to complete the post-shadowing assessment. You have 2 tries to get over 70%. And once you do that and pass the assessment with over 70%, you will be eligible to download your certificate. You can only download your certificate after you hit Finish Course. If you do not hit Finish Course, you will not receive your certificate. So please ensure that you do not miss this step. After you click Finish Course, your certificate will be downloadable immediately, and you can always find it in your profile under the Certificates tab. If you experience any issues or have any questions, feel free to email us at info@prehealthshadowing.com, and we'll be sure to get back to you. Thank you all for joining us today. This is the end of the virtual shadowing session, and I hope to see you next week. I invite you to disconnect from the call.
Hey, Nina, can you go back to the QR code for the GoFundMe page?
Yes, I can.
Thank you.
Also, I forgot to mention, by sending out the GoFundMe QR code, you guys can actually receive verified virtual volunteering hours. And so be sure, if you send out 15, sign up to become a volunteer on our website, and we can finalize that process for you.